Thank you very much, Alero. While we were seated in the guest room, Chikwe said something about us having met in the UK, Professor Green's time, and that's the first time I met Alero as well, because she was working with Professor Green. Distinguished panelists and distinguished ladies and gentlemen in the audience. It's very critical that in trying to project a change, that we assess where we are. And that's probably the best way to recognize what are the things we are dissatisfied with, and therefore what should form our priorities. There was a feedback about the time lost in terms of strikes and loss of productivity in our healthcare sector arising from strikes. And if we trace the strikes, essentially they've been driven by interprofessional rivalry. So you can predict, and if there was a betting game, you'll probably be a winner and be a millionaire several times over, that whenever NMA, the Nigerian Medical Association, goes on strike, just wait for a resolution to be achieved with the government, and then you have JOESU and all other manner of alliances and unions. At the heart of it, a lot has been done to investigate why it's that way. There have been presidential expert panels, there have been interministerial panels, and still the last report of the presidential expert panel that was released in 2014 December, I don't think it lasted a week in the public domain before it was torn to shreds by the warring rivals. And the sad part of all of this is the patients whom all these healthcare professionals have sworn to do their best to prolong their lives and do no harm to are the victims. And it's getting to a point where the loss in confidence in the health sector is such that even if we start to get efficient functioning, we may never get some people back. They've gone to faith healers and they've come to conclude that faith healing is the best. They've gone to Babalawo, or they've gone to India with $1 billion of Nigeria's hard-earned foreign exchange in tow. So what can we do about this? One of the ways we try to look at in quality improvement circles of how can we make a change, I tend to enjoy models because they're interesting, they're easy to remember, and today the three things I'll talk about briefly will be built on those models. The first one is what they call in quality improvement circles the 5 W's and the 2 H. So the question is, who are we training? I said interprofessional rivalry is at the heart of many of the systems shut down, and these health professionals, who are the people we're training? We're training individual healthcare providers. We're training medical doctors, we're training pharmacists, we're training nurses. All of them we're doing in silos. And if we want to put a dimension of numbers to it, we're training, for instance, for the medical doctors, just about 2% of those who desire to study medicine. So you can see that these are very competitive fields, and we get the best of our young minds to go into it, and the outcome down the line is being thwarted. What they're going in to do is not being achieved because something is going wrong in the way they're being produced and in the way they're practicing. If we look to what exactly are we teaching them? As pharmacists, we've just had a review of the pharmacy education curriculum. We've had a rethink to say, how should pharmacy education be in this 21st century compared to what we've been doing before now? We have pharmacists that hold their own everywhere in the world. If you go to the US, a significant proportion of pharmacists there, especially in the state of Florida, are Nigerians and doing very well. So we've produced pharmacists who are very good in what they do, especially when it comes to the pharmaceutical sciences. But many of them, is until they leave the shores of this country that they start to truly apply the fundamentals of the clinical aspects of their profession. So what are we teaching? We're teaching sciences, and we're teaching them also in solo. If we look at the where we're teaching, I talked about the 2% out of the 230-something pupils, students who apply in JAM, 2% being taken The reason is because we are training in brick and mortar environments. I can't count the number of courses I've done recently on platforms like Coursera on the internet, on platforms like Harvard X, edX. These are very innovative mechanisms that is making training, in-depth training, possible using the technology that is available to everyone worldwide to be able to do. But we've restricted ourselves to those same faculties that were there 30 years ago or 50 years ago, as the case may be. That dimension has to change. We also look at the dimension of the when. We have fixed admission cycles. So you run a September to June cycle in most of the teaching institutions. I know in schools in Canada, for instance, they have 4 semesters divided according to the climate, spring, fall, and all of that, summer and winter. And they admit students in many of the institutions each of those semesters. So what you have is a capacity utilization increase such that there's a constant motion. There are people who are in year 1 and there are people who are in year 1 but at a different stage. This we have to do in that the production, the quantity we have, the quantum we have of healthcare professionals is inadequate, and when they're even distributed, they're not working effectively because of loggerheads. If we look at the where as well is the main thrust of my argument, which is that we're training doctors in their clinical settings in the teaching hospitals mainly. And you're training many of the pharmacists that I know in separate institutions in the academic universities. And you have a situation where someone who ought to have significant exposure to the interaction between the drugs that he is dispensing to patients and how they're working in the clinical setting, but he doesn't have that clinical exposure. I am fortunate to have gone to the University of Lagos because there, pharmacy, medicine, and the other allied health professions, we were trained together in Idiaraba at the College of Medicine. And so we did the basic medical sciences together in anatomy, biochemistry, what have you. And each one knew the relative strength of the other. Someone with whom you have been roommates and you've exposed yourself to your strengths and weaknesses will not develop down the line to have a superiority complex over you, or you have an inferiority complex towards him, because you've both been socialized together. And this is something that is missing. But the challenge is not so much the how we are bringing these people together, but it is also in, are we alone in this problem so that we think it's a Nigerian problem? It isn't. The thrust of interprofessional, which is the ISP, as I call it. I was joking with the lady from Shopee recently that I learned Shopee is probably defunct because I passed by the Express. The ones in Lagos, we know Shopee most by the FEMA, the guys in black by the toll gate. And just this week, they're no longer there because there's the likelihood that Shopee will probably be scrapped. But the thing that has happened with the environment with Shopee is that you had a design that made sure it measured outcomes at the end of the interventions they did. So you can tell that if you're changing from one system of doing something or adopting some new policies, what are the outcomes? University of Washington in Seattle in US has championed this to look at how they're training health sciences and to design a new system. And they have proven in the Institute of Medicine is a bridge to quality. The Institute of Medicine is the leading academy for medical science in the US. They've demonstrated that when you train healthcare professionals together and when they eventually go on to work in collaborative practice teams, you have better outcomes. Because part of the things that they're doing from the beginning is that they're sharing similar values and ethics. They're not doing these things independently. They're having communication, skills, training, interpersonal relationship skills. All those things are developed from their foundation. And they're moving through this from the pre-qualification stage onto the postgraduate and onto the continuing professional education system. So you have a purposeful collective milieu because the patient is not really interested in whether it is ex-professional that is going to be the one to save his life. It is that when they work together as a team, is better assured of the successful outcome of treatment for him. And that's why my charge to the Nigerian healthcare professionals and the policy makers is that the time has come now, as pharmacy has done, and at that summit, it included amongst the panel a provost of the College of Medicine, a medical doctor, to share perspectives and say, how can we do this better? As pharmacy has done to review its education curriculum, all other healthcare professionals should do similar, and there must be a deliberate policy to make sure that training of healthcare professionals is subsequently interprofessional, that practice, when they come out, can be collaborative and serve the interest of the patient. That's the trust I want us to think about. Thank you.